Assalamu alaikum, everyone. We're just going to keep moving right along to stay on time. It gives me great pleasure to introduce the next speaker, Dr. Ali Farooq Iqtedar. He's a local Lahore boy who came to AKU, was my class fellow, trained at Dartmouth and Leahy Clinic, and is currently the Director of Interventional Cardiology at Indiana University, Saxony and North Hospitals. Extensive experience in CTO and left atrial appendage closure, and he's going to be talking to us about feasibility of LA appendage closure in Pakistan. Over to you, Farooq.
Thank you. I want to make sure that I'm unmuted and
yes, we can
get started. Can you guys hear me okay?
We can hear you.
Okay, great. Perfect. Thanks. Well, thanks for letting me go a little earlier. So I'll be talking to you about left atrial appendage closure and as a viable option for stroke risk reduction in atrial fibrillation. So we all know that atrial fibrillation is responsible for strokes, and 90% of these thrombi originate from the left atrial appendage. And these are particularly debilitating strokes. Stroke overall is the #1 cause of adult disability worldwide. And AFib-related strokes particularly have higher disability, 1.5 times higher disability, 2 times higher mortality, and substantially reduced quality of life for the survivors. And there's a very high mortality rate as well. So obviously the standard of care is to use oral anticoagulation, but increasingly left atrial appendage closure as a one-time minimally invasive procedure has gained traction with under a day's stay, and usually the procedure being under an hour from start to finish. So just a little bit of background of the data that allowed us to use the most commonly used devices, the Watchman versus Amulet in the United States. The Watchman data is primarily based off of the PROTECT trial, the PREVAIL trial, which led to FDA approval in 2015. And I'll talk a little bit about the legacy device, but really the standard of care with substantial improvement in safety of the procedure and device implant is with the Flex device, which was approved after the Pinnacle Flex trial results. And since 2020, it's really become the standard of care to use Watchman Flex. The Amulet was relatively late to come to the United States. The ID FDA approval was in 2021, and this device compared to the older Watchman device. So we'll look a little bit at the data because I often get asked this question about which device should be used. In the United States, the answer is very straightforward at this point. The market is primarily geared towards Watchman Flex. Overall, in the IDE, Amulet was found to be non-inferior to the previous generation of Watchman device. It does provide a slightly different mechanism of closure of the left atrial appendage, with the disc covering the orifice and the main body being covered by the Amulet plug. However, there is more of a learning curve, and even in the trial, there were higher procedural complications with the Amulet. So the Watchman Flex, which is the iteration that is commonly used, I'm going to be focusing more since I have a limited amount of time. You can see that this device has the tines are curved inwards and folded in, which actually was a sea change in the safety of left atrial appendage closure. And really, compared to the old device, I put some data up here, the issues that used to occur with the older device-related thrombosis, leaks, that really has essentially been resolved. And so safety has improved tremendously for those who are considering left atrial appendage closure as part of their armamentarium. Previously, the safety events rates ranged anywhere from 1.5 to 2%, but that was 0.5% or 1 in 200 in the Pinnacle Flex trial, with a very high procedural success rate. And even in this trial, almost 96% patients were able to stop their oral anticoagulation successfully at a 45-day interval. So this has been borne out. You know, trial data and registry data sometimes is very different. And registry data for 69,000 patients across 800 centers performed essentially the same as it did during the trial, with safety events being at about 0.5% and the ischemic stroke rate being 1.2%, which is lower than would be expected with oral anticoagulation and lower than the legacy Watchman device as well. Recently, HRS also published a meta-analysis comparing the two endovascular device options. And again, there was a substantial difference between Watchman Flex versus Amulet for safety purposes. So we'll talk a little bit about the procedure. And so what you need is it's done with general anesthesia. Very rarely would I do it with moderate sedation. TE over ice. You need to have a good imager that can be a cardiac anesthesiologist or a general cardiologist with TE skills. In the beginning, you want interventional cardiology and EP working together, but a lot of teams have split up and perform these independently as long as you have the good transeptal skills. Critically important are left atrial appendage dimensions. We'll go a little bit into that because that helps plan the procedure. I want to make sure that there's no pre-procedural effusion. And of course, left atrial appendage thrombus would be an absolute contraindication. So at baseline, you want to obtain these views at 0 degrees, 45 degrees, 90 degrees, and 135 degrees to truly define the anatomy and the dimensions, width and length of the appendage, and define what sort of appendage morphology you're dealing with. Left to right, these are easier to harder anatomies for closure purposes. Windsock is the easier one. Chicken wing is somewhat harder. This is a superior wing taking off at the back of the appendage. Sometimes we have to implant the device into this and land the device here at the ostium. And then the hardest ones tend to be shallow broccoli type left atrial appendages. So for device sizing selection, we have options between 20 to 35 millimeters. And you want to aim for at least a 10% compression, but erring more towards higher compression, which is a protection against device embolization and makes it more secure and the anchors implant properly. So during the procedure itself, we're going to get femoral access, get transeptal. Again, different methodologies can be used. At this point, typically I use the Baylis system for getting across. Get the Watchman sheath and guide it in safely into the left atrial appendage with a pigtail catheter, do an angiogram, and deploy the device. This was a case about 6 weeks ago. Just picked the first case that came up on our PAC system, and to just showcase what your device deployment should look like. So nowadays with X-plane, we can look at the 45-degree angle and the 135-degree angle simultaneously. Here you can see the sheath, and with the connector deploying the device under the limbus. This is the pulmonary vein. The device is at the ostium. And here in 3D, you can see that the device is tucked in under the limbus.
Farooq, you have 2 minutes left.
And pass criteria must be met. These are the position, anchor, size, and seal to make sure that the device is secure. Once that's the case, you release the device and then discharge the patient. At 45 days, you want to repeat the same process, the same patient at 45 days with the device nicely seated, and we see through thorough interrogation that there's no leakage around the device. At that point, then we have different options. The newer option is to no longer use oral anticoagulation, but just go directly with dual antiplatelet therapy for 6 months. But a lot of individuals, based on risk categorization, may still require 45 days of anticoagulation. After the TE, you can transition to DAPT and further down to aspirin. So briefly, I'll end up with the cost-benefit analysis as we talk about how is it feasibility of a device. Certainly, there's upfront cost. If you look at this blue line for left atrial appendage closure versus NOAC and warfarin. But over the patient's lifetime, in about 4 to 5 years, you see a cost-benefit analysis trend over towards benefit for left atrial appendage closure as you start accounting cost of the medication, also cost of hospitalization, stroke, bleeds. And again, looked at it from a different perspective on a recent study in 2023. There's a higher healthcare burden when you have stroke events, not just for the patient, but also for the general healthcare system. So the development is at this point where we are actually going to go ahead and directly do a trial with NOAC, which is the standard of care. And I think that will help transition from a 2B indication to a 2A indication. So I think, again, penetration within developing countries remains relatively low, but it's an excellent device option for patients who are high stroke risk and yet have high bleeding risk as well. The Flex device has made it a safe and reproducible procedure with improvement in quality of life of patients, overall healthcare expenditure reduction after the initial cost. I think close partnership with industry, hopefully this can be introduced to Pakistan as well. So I'll conclude over here and take any questions.
Thank you, Farooq, for a very comprehensive talk.